Oh, was it a glass of water? Right. So, it's very nice to be here. Anyway, so here, and I was talking about respiratory infections, so I've just got to change track into the STI world for a bit. So this, just to sort of lay the scene of what we do in Edinburgh. So Scotland is relatively a nice picture of Scotland, and just in case everyone doesn't know where it is. We centralise a lot of our STI testing just because all small labs will struggle to do proper GC susceptibility testing. So all of the GC cultures, once they're cultured, they come to us and we do that for 7 antibiotics, not 6. We also still do GC NAT confirmations but we're increasingly likely to stop that. And then we also do typing, so we do typing using the NG-MAST process. And we also, for a small number of people, we do the LGB PCR, just because there's such small numbers requested for it in Scotland that we do that in one central place rather than have multiple labs trying to do 4 or 5 samples. Next, just a picture of Scotland, just, you know, it's nice. It's got hills, unlike here. And I worked here for 5 years. I know that it hasn't got many hills. Sorry, I've sort of got to start to repeat there. We'll move on to the next one. So this is the thing that's happening is we've got increases in syphilis, we've also got increase in gonorrhoea. And these are the numbers of tests, and obviously the thing that's changed is the number that we're now just getting positive with GC NAT. So we have 47%. We have positive without any resistance data. So we're just getting many more cultures anyway as well, but we're also getting a lot of positives just with GC NAT data. And then this has been the other thing, that monitoring the resistance in GC, so we're doing all these MICs. We had an outbreak with resistant azithromycin back in 2007, but then at that point the guidelines changed, and we then brought in the ceftriaxone and the dual therapy treatment, and essentially for a few years we were in this wonderful land of no resistance, and then suddenly that all started coming up again, the azithromycin resistance. You notice that I need my glasses for this. The red line is the number of episodes, and they've kind of increased up. And then we've also the blue line is the total number of episodes, and you see that's increasing up as well. So on my next slide, this is just showing some of the data that we have on recapture on all our different GC cultures. And the thing I just want to highlight is, if I can do that, is the ciprofloxacin resistance, which is the orange. And this is sitting from sort of 2005, 2016, 2017 at around about 30%. So 30% of our cultures have ciprofloxacin resistance. So in 2019, the UK has gone down a new route, having had dual therapy for a long time with ceftriaxone and azithromycin. We have decided to move away from using azithromycin and go for ceftriaxone 1 gram, so slightly higher than the level that's recommended in the European guidance, was 500. Intramuscularly is single dose. But very, very prominent in this guidelines is when antimicrobial susceptibility is known prior to treatment, that ciprofloxacin 500 mg orally is a very good second option. The challenge is that usually, if anybody's symptomatic with GC, you will start the treatment straight away, and you're not going to wait for the MICs to come back, which generally take about 7 days or so. So that's the issue. But there is now, that's why I'm here. There is now a SpeeDx assay that can potentially do that. So, and we've also done quite a lot of whole genome sequencing for GC, And one of the things that is sort of slightly unique about the ciprofloxacin is it is really just one SNP. Even when you do all the genome sequencing, it is one SNP mutation that's conferring the resistance, whereas the azithromycin is a lot more complicated, and we would need many more SNPs, and is slightly probably wanting a metagenomic approach, and the ceftriaxone is again a little bit of an unknown quantity for monitoring. But for the ciprofloxacin, we're talking about one SNP. And this assay essentially also tells you whether you've got GC, so just to make sure that you really have got GC, but also gives you the wild type and the mutation and an internal control. And this is all done in one well. So the idea is that you take your original samples, you extract them. So for this study we used the ECCMID, and then it goes onto your real-time PCR platform, and for us we use the ABI 7500. So our aim was to evaluate the clinical performance of this assay with the gyrA and compare this to our antimicrobial sensitivity pattern. So we went into our database, and we went for anything that we had the culture MIC from, and we also had the original samples on. So we were testing original samples, but we had at the same time point the MIC values that we'd done on the cultures on those people. And then what we wanted to do was also, we wanted to make sure it worked for rectal samples, cervical samples, throat samples, urine samples. And then we ended up with 167 samples in total, and we tried to sort of make sure it was roughly even amongst those. And then we broke them down into some of them being sensitive. So for us, that's less than 0.06, and some of them being resistant. So also within those different sites. So tried to get a sort of broader mix as possible, so all variables were tried out. This is the MIC ranges that we had. So essentially for Cipro, generally it's either very sensitive or very resistant. There isn't. So we did have a few in the sort of intermediate place, but that's generally you see with ciprofloxacin resistance, it's either one extreme or the other. So this is just going through the results. We had 167 samples. We had 159 that we got complete results first time round. 6 had GC detected, but the gyrA was negative. And 2, we had an invalid result, so the internal control failed. So what we did with both of those was just repeat them, because I think it's perfectly possible that the GC part of this assay may be slightly more sensitive than the gyrA bit. So that is potentially a possible result. And we then, on the 159 complete results, we had 2 discrepant. So when we teased out all of this, we found that the ones that the assay was struggling with was the weak positives. And I think weak positives will always be an issue. So those were some of the ones that are discrepant. And then the 2 that were different to what we had was when we went back and recultured them, and we went straight from the culture, they actually had a different result in the culture to the original sample. So we had 2 where the culture result, so the culture result gave us exactly the right assay with the SpeeDx assay, but the original sample was different to the culture. So that, I mean, they were taken a little bit far apart. They weren't on the same day, so potentially that was the difference with those 2. But ultimately, we end up with a really, really good agreement, so 98% agreement. We excluded the 4 where we didn't actually have a gyrA result because of just low copy number. So from this point, we reckon we can write this up as a validation. It would be suitable to roll out across Scotland. And then you get into the feasibility of how easy would that be to do. So we already know that those who are culture being sort of had the culture samples taken in the sexual health clinics are largely symptomatic, and those people are going to be started on treatment almost immediately. But then we would also have those that have the GC NAT positives. They're already all sent to us. The samples are sent daily. There's a 5 p.m. collection across Scotland, and then they arrive with us at 9 o'clock in the morning. And then we have an automatic link to our sexual health databases, which takes all the results to the clinic. So there isn't a delay. Once we have a result, it goes directly into the interface with all the sexual health clinics across Scotland. So we've got a neat reporting system. So those things can help us have a fast turnaround time. So this is just sketching out how we propose to do it. Is we have a GC-NAT positive on the local platform, all sites. We would test all different sites, because at the moment I wouldn't want to say that a genital inferred everything that was, if the genital site was susceptible, I'd still want to test the throat and the rectum. But we can carry on looking at that over time. And then those would be reported by the local lab as GC-NAT positive, Cipro testing to follow in 2-3 days, check result before starting treatment. So the sexual health clinic can start to think about, or the GP can think about them coming in to receive their treatment. And then we would run the GC Cipro assay on day 2, and then report it out either on day 2 or day 3, because we'd run the assay every day. And then it would either be reported with GC-NAT positive, Cipro sensitive, suitable for treatment with ciprofloxacin. So we would guide them to what treatment they could use, as stated in our BASH, which is the British Sexual Health Guidelines. Or they would be reported as Cipro resistant, and standard treatment use the ceftriaxone. So the comments on this approach going forward, I mean, some will already be on treatment, but this seems the most pragmatic, simple way to make this happen. 14% of them of the GC come from primary care, so they're unlikely to have already started on treatment. Most treatment is done in sexual health clinics in Scotland. So if a patient is diagnosed positive in primary care, they're then referred to sexual health, because that's the place that is happy to do the ceftriaxone treatment. So there's always a delay from somebody who's asymptomatic going from primary care up to sexual health. We'll test all the sites, because we don't yet have the data on which site, whether a throat swab always tells you the whole picture of sensitivity. And we'll prospectively be able to compare this with culture, and where we still get the culture results, and that we're doing the MICs, and we've got this assay. So we'll be able to have a longer term prospective evaluation of what we're informing. So we've got that as a further check balance in the whole system. And longer term, we just want to develop a metagenomic approach so we can guide antimicrobial treatment, because the number of GC-NAT positives where we don't have AMR sensitivity results is just increasing. And so there are more antibiotics. At the moment, we're on ceftriaxone, but if we were ever to lose ceftriaxone, we would not have too many other options out there. So and at that point, I think I'll stop. And thank all the people in the reference lab who work on this, and the SpeeDx people as well. Thank you.